Hi, good evening, everybody. I welcome all of you to another exciting ICU webinar series, which is brought to us by the Indian Chest Society. At the onset, I'd like to thank our President of ICS, Dr. J.K. Samaria, sir, the chair and the brainchild behind the webinar series, Dr. Amita Nene, madam, and our secretary, Dr. Rajadhar, sir. I also like to thank and extend a warm welcome to Sipla, especially Vipul and Harshal, for making this such a smooth process. Now, today's topic is going to be ARDS and its role and its update in management in 2025. Now, we've all spoken about ARDS and heard and read a lot about acute respiratory distress syndrome. And it's a dreaded complication which we all pray we don't have to experience or get involved in the management of our critical patients. Time and again, there have been changes in the management, and let us all understand what is new in 2025. Now, today, to talk on this important topic of ARDS in 2025, I want to welcome and invite an exceptional speaker and excellent critical care physician, Dr. Khushrav Bajan, sir. Now, Dr. Khushrav Bajan, sir, needs no introduction. However, I have the privilege of introducing him. He is the head of Department of Emergency Medicine and a critical care consultant at the prestigious PD Hinduja Hospital. Sir has been the gold medalist in the first certificate course held by the ISCCM in 1999. He is the first to bring the AHA BLS ACLS course in India in 2000. He is the chair of the relief team of the Bhuj earthquake in 2001. The recipient of the Lifetime Achievement Award in Emergency Medicine in India in 2015. He is the recipient of the Fellowship of the Critical Care Medicine College in India, co-author of the textbook of Emergency and Trauma Care in 2017, co-author of the textbook of Signs and Symptoms in Clinical Practice in 2019, editor of the Critical Care and COVID-19 Compendium published in 21, editor of the Compendium on Sepsis published in 2022, recipient of the prestigious Times Healthcare Award as a legend in critical care medicine in 2018, recipient of the Economic Times Inspiring Infectious Disease Specialist Intensivist in India in 2022, and persistently and consistently featured as the top doctor in Bombay since 2000, if I may say, but officially by India Today since 2019. So without wasting any time, it's my privilege and honor to welcome Dr. Bhajan to enlighten all and educate us all on the important topic of ARDS. Over to you, sir.
Thank you so much, Dr. Avia, for that introduction. I hope you don't cut my speaking time from that. I am going to right away start off by sharing my slides, and I hope I'm all set. Is it okay? Am I audible, visible? Yeah.
Yes,
okay.
Sir.
So before we start on talking of ARDS in 2025, I would like to pay my tribute to Luciano Gattoni, who was the pioneer in research in ARDS. And today our understanding of ARDS and lung ventilatory strategies is because of this one man. So we cannot, overemphasize the contribution that he has made. My slides are...
Bhajan, please help.
Yeah, it's moving. Yeah, okay. Fine. So basically, I'm going to talk in the next 20-25 minutes about how do I manage and how should we be managing ARDS in 2025 with a lot of literature as well. And I thank ICS for allowing me to talk today to this August gathering. So we start with a definition of ARDS, which is extremely controversial. 1967, two big things happened. One, I was born, and then Ashbuck found out the definition or the understanding of ARDS. Murray in 1988 said that there is a lung injury score. X-ray findings happened. Then the main definition was the AECC in 1994. Then came the Berlin definition in 2013. And then the ESICM gave some guidelines in 23. And then in 23-24, we had a new global definition post-COVID, which was an online definition. And we'll just look into that. So the evolution of ARDS definition is going through the last 50 years, and we have to know that because the definition changes, it only means that our understanding is getting deeper and wider. So what is this new ARDS global definition as of 2023-24? What they have done is they have continued the Berlin definition. They have added the PEEP, they have used the PF ratio, added the PEEP as in Berlin definition, but they have used the PF ratio to divide it into mild, moderate and severe. And they have added a few more things, and that is they have used the ultrasound to try and rule out cardiogenic pulmonary edema. They have also used an HFNO and NIV, and they have another thing that they have done is in resource limited settings, if an ABG was not handy immediately, they have looked at the SpO2, and instead of looking at the PF ratio, they have looked at the SF ratio, and so on and so forth. So there were lots of controversies after this ARDS new global definition actually came in. We also know that it is ARDS is very complex and it has got a lot of stages which are interlaced. There may be pulmonary infiltrates, hypoxemia, and the wedge pressure needs to be low. But beyond that, there is so much more going on in the lungs. There is an exudative phase, there is a fibroproliferative phase, etc. And we really don't know whether to give these patients fluids, how much oxygen, how to ventilate them, etc. To add on, this is a very latest list of the causes of ARDS, which are protein, and we also understand that beyond bacterial infections, pneumonias, there could be drug overdoses, there could be near drowning, which are all the other mimics of ARDS, and then TRALI can also be one of the parts of ARDS causes. So it's just ever growing in the field of ARDS. Then came a very classic issue, and they said that it's a shambolic one in 2023. And they said that ARDS has always been a controversial topic and ARDS is not a real thing. The problem is there were many societies which were against each other and they did not come to a consensus. For example, for paralysis, ATS said that it should be a patient of ARDS should receive paralytic agents, whereas ESICM said no. PEEP, for PEEP, ATS said that there should be higher PEEP used, whereas the ESICM did not agree. And then the high flow nasal oxygen and the NIV, again, ATS ignored the topic, whereas ESICM this time took the lead. So it's very controversial yet to understand what we are dealing with when we say ARDS. And then our mentor and a huge intensivist world over, the Jean-Louis Vincent, said that we've never seen a patient with ARDS in light vein because it's not a disease, but it's more of a syndrome. And therefore, we need to understand this before we dive into how to manage an ARDS. And this brings me to another cartoon here. What brings you here, ARDS, and no one believes in me anymore is again, just to get the discussion rolling. Before I again say how I manage a patient, I would like to make three important special mentions of three conditions. One is that we talk about ARDS in terms of phenotypes and personalized medicine. We have divided them into hyper and hypoinflammatory. The hyperinflammatory basically can do well with liberal fluids and maybe simvastatin, but hypoinflammatory do better with higher PEEPs and less of fluids. And then you can make a matrix here where you divide the phenotypes A, B, and draw a matrix, and it can actually tell you the prognostication of an ARDS patient. And here you can see that the hyperinflammatory phenotype basically has a lower mortality if higher PEEP is used and improved mortality if lower fluid regimen is used. And this can be with high IL-6, TNF-alpha, and low serum bicarbonate levels, etc. So we need to now look at phenotypes when we talk of ARDS. The second thing that I would draw your attention to is the right ventricle in ARDS, which was which was ignored for many years, but this has an impact on the mortality, and it is pretty common now in severe ARDS to have a right ventricular dysfunction, almost to the prevalence up to 50%. And the factors for this are hypoxic pulmonary vasoconstriction, hypercapnia, and invasive ventilation with a high driving pressure, which we will allude to in a bit. So this is a good diagram where it shows how ARDS can actually affect the right ventricle. And I just mentioned all this. There's vasoconstriction, there is hypoxia, there's microvascular thrombi, endothelial damage, decreased lung volume, and much more, which actually leads to this RV dysfunction, leading to a much higher mortality. And then the third thing I would like to talk about, because non-invasive ventilation and HFNO has been included in the newer global definition. We always talk about avoiding 𝐕LI when we are doing mechanical ventilation, but we need to also talk about P-SILI, which is the patient-induced spontaneous lung injury. And this would be also hand in hand when we are not using a ventilator on these patients, or we are allowing HFNO, etc. And here the main issues are the diaphragm gets injured and paralyzed, and there is a lot of dyssynchrony because of this. And the term used for P-SILI is the pendulum effect or the pendulift effect, which will actually lead to the P-SILI. So having mentioned all this, now I would come to the main topic, and that would be how do I manage ARDS in 2025? In order to manage ARDS, we'll first talk about the ventilatory settings, and we need to avoid the VALI or the 𝐕LI, which is volume trauma, atelectro trauma, biotrauma. And without graphics, we really can't understand how to ventilate an ARDS well. We have guidelines, but we need to understand how to put them across onto a patient. So here you can see that there is a CT scan which actually tells you how there is a collapsed lung, what is the volume of overdistension, and then what are the shearing forces that may happen. And it also shows that a lung is compressed almost to 30% of its original volume and giving us a baby lung concept here. Looking at the hysteresis, we can know that this is a lower inflection point where if you increase the pressure, the volume does not increase, but after that, an increase in the pressure would definitely increase the volume, but up to that level, there is atelectotrauma. And if you overinflate where the tidal volumes are high, then the upper inflection can cause beaking, and therefore you need to know that there is FRC here, and increasing the PEEP around the inflection, lower inflection point might prevent atelectasis, and avoiding too much tidal volume and overdistension can be seen as beaking here, can be done by decreasing the plateau pressure. So these are the principles which we need to understand. And then if you are ventilating them, looking at the hysteresis and correlating it with the CT scan here, you have a safe zone in between where improving the pressure, increasing pressures would improve the volume and therefore indirectly improve the compliance of the ARDS lung. Having said that, about the ventilatory strategies, we have to talk about the NIV here. And NIV has been tried, but it's a grade 2C evidence that we should not be using NIV. NIV should be reserved only for those mild ARDS patients who are hemodynamically stable, easy to oxygenate, do not need immediate intubation, and have no contraindications for its use. There are trials which have been done on NIV alone and high concentration supplemental oxygen by a Venturi mask versus NIV actually showed that there was improved oxygenation and lower intubation rates. But I don't think this is a fair comparison. In another study where they did ARDS, in ARDS hypoxic respiratory failure, they found an increased mortality associated with NIV as against to HFNO. And then they also found that if you did use NIV, helmet delivered NIV had a little better improvement on the intubation days and the mortality. NIV failure may be associated with the etiology of the ARDS, and this is quite interesting that patients who had a pulmonary etiology, primary pneumonias, etc., and had ARDS had slower improvement and more NIV failure and increased mortality. But the secondary or the extrapulmonary etiology probably did better, especially dengue-induced or maybe COVID-induced. So we have the ARDS net protocol where they told us tidal volumes, how much to use, they told plateau pressures, they told PEEP, and there were lots of studies which we will touch upon later. But this is a very easy diagram to understand what we are doing. We must use a tidal volume of 6 to 8 ml per kg predicted body weight, which is important, which accounts for the height and not only the weight. we must keep the PEEP set to prevent the atelectasis, which may be adjusted with the lower inflection point, and then the plateau pressure should be kept less than 30 centimeters of water, and patients who are non-compliant or have poor compliance would need higher plateau pressures, but our aim is to restrict it to less than 30, and this is nothing but a lung protective strategy that we will talk about soon. Once you have looked at 6 ml to 8 ml per kg body weight, ideal or predicted body weight, you can then keep the plateau pressures less than 30 and then measure the driving pressures. Driving pressures less than 15, then you are doing well. If the driving pressures are higher than 15, then you might need to recheck your ventilatory strategies, and you might want to do some management in trying to get the driving pressures better by adjusting your PEEP levels and relooking the ventilator graphics. So this is basically a lot of things about driving pressures as well, besides looking at low tidal volumes, low plateau pressures, and now it is the driving pressure to be maintained at 15 and less, and reduction in tidal volume, optimizing PEEP, recruitment maneuvers, neuromuscular block pairs, and prone positioning would probably help us in reducing this driving pressure. We also talk about something called as the stress index, and we must keep it less than 1, as you can see from this graphics. And now the newer terminology is the mechanical power. I don't understand much about it, but probably we need a little bit of understanding. It not only takes the delta pressure, the changes in pressure, but it multiplies it by 4 times, and it also uses the respiratory rate. So there are lots of factors which actually look at mechanical power. This is just a simplified way, and Costa and colleagues had actually shown that there was increased mortality if the mechanical power was higher in certain patients. 1 point reduction in driving pressure is equivalent to 4-point reduction in the respiratory rate, and this is what they did. And this is a very nice picture where they have looked at physiological, epidemiological, and personalized way of looking at the mechanical power. And they have said that the mechanical power is same to ventilation as an SCVO2 or SVO2 is to the body hemodynamics or hemostasis. So it is a kind of a comprehensive kind of picture which takes into account the shearing forces and many other things. So several studies have shown that there is a clear association between mechanical power and the mortality, and in summary it is derived from a lot of foundational mechanisms that we have seen here. Recruitment maneuvers, again very controversial, but a rescue therapy can be done in various ways, a staircase way or a stepwise way, and you can keep a pressure in the lungs at about 30 to 40 centimeters for about 30 to 40 seconds, but it is fraught with a lot of complications. And this is a very nice diagram to understand how any one procedure or one intervention is not going to make a big change. Before recruitment and after recruitment, we have divided these into 2 categories. One is the non-responders and second is the responders. As you can see here, the blue is the overdistension, the red is the atelectasis, and then the normal lung is in between. So here you can actually see that these patients are the non-responders because the overdistension has increased and the atelectasis has also increased. But in the responders, atelectasis has reduced, overdistension is same, and there is more normal aerated lung. So a recruitment maneuver you need to understand, and sometimes CT scans also help in. And the negative part of a recruitment maneuver could be increased intracranial pressure, decreased cardiac output, risk of barotrauma, and the list goes on. Some other modes have been tried are HFOV, which is high frequency oscillation, and APRV, and this is how the graphics will look. But I would not say that you would need to use this, and we can discuss this later in the panel. And there was a MOTE, OSCILLATE, and OSCAR trial, which did not really show much of a benefit. Coming to the non-ventilatory strategies, I would not say modes here, but there are multiple other things that you need to do besides the ventilatory modes, and that is proning, and which is definitely to be done in most patients, whether ventilated or non-ventilated. paralytic agents, conservative or optimum fluid therapy, appropriate oxygen targets, pharmacotherapy in terms of steroids, prostacyclins, avibtalil, simvastatin, aspirin, experimental, proper nutrition, and then ECMO if you may. So we will talk about just the important ones here. There is no time to discuss each one. And we know that proning can improve the VQ mismatch. It can improve it to a proper match. It can increase the FRC and prevent atelectasis. It facilitates secretion drainage maybe. The heart sits on the sternum and therefore the pressure on the lung is less. Decreased transpleural pressures will improve the lung in the non-dependent areas, and the ventilation will be improved because of the plateau pressures being more uniform. And as you can see, this is the supine patient and this is the prone patient, and you can actually make a difference, and the CT scans can also be seen here to see the difference in them. In summary, for proning, I would like to use these 5 P's. There is a way of proning, there is a way of unproning them. So you must prepare, you must plan, you must perform it properly, you must protect the patient, the lines, the tubes, etc. And then you must be perfect at the procedure so that you do not cause more harm whilst proning, because now we have enough studies, especially the PROSEVA study, which says that if you prone more than 12 to 16 hours, then there is a humongous benefit on the mortality. Then a little word about the steroids in ARDS. We had this study which came up from Villar in the Lancet in 2020. They used dexamethasone along with conventional treatment. First dose was received within 30 hours, but immediately 20 milligrams was given for 5 days OD, and then 10 milligrams was given from 6th to 10th day, and treatment was continued till day 10 or till extubation. And they found a huge, quite a good difference on the mortality. And basically, I have no time to go through all this, but there was a change in the ventilator days, all-cause mortality, ICU survivors, etc. And the adverse effects were not very significant. There was hyperglycemia and very little or no difference in the newer infections, which we are always worried about with dexamethasone or any form of steroids. And therefore, that came as a conclusion. Hydrocortisone, if there is pneumonia, community-acquired pneumonia, severe one, which is causing ARDS, then this is the study in 2023, where now they use hydrocortisone 200 milligrams for 4 days and up to 8 to 14 days, depending upon the PF ratio. Again, there was decreased death rates in the hydrocortisone group, almost half, and there was no significant difference in the cumulative infection rates or the GI bleeds. As regards NMBs, now as I spoke about the shearing forces and the pendulum effect, Accurus trial and the Rose trial actually said that if you use NMBs, you might be able to reduce the damage or the villi to the lungs and improve the mortality. Avibtalil is a newer VIP, which is a human vasoactive intestinal polypeptide. It is still in the research, but many people have used it. I haven't got much of an opportunity, but I know about the drug. It has anti-inflammatory action, increases pulmonary surfactant, inhibits the alveolar epithelial apoptosis, and it preserves the pulmonary tissues. So basically, it can be used in certain cases. Balancing fluid therapy. So I have just made this chart to try and understand what we should do with fluids along with ventilatory strategies. If the patient does not have shock, then conservative and then later de-resuscitate, improve oxygenation, and it may reduce mechanical ventilator days. If the patient has hypotension, then liberal initially and no de-resuscitation, but try to maintain organ perfusion along with the lung and don't only look at one organ. If the patient is hypoalbuminemic, then you might be using albumin plus minus diuretics. There are some studies on diuretics as well in ARDS. Then you might look at the phenotypes. If they are hyperinflammatory, then conservative fluid, and hypoinflammatory might get liberal fluid. And then if you have ARDS along with severe acute brain injury, then always avoid hypoperfusion. So what I'm trying to say here is that fluids cannot be always conservative as advised in the FACT trial. but you need to see your individual patient and decide what you need to do. What oxygen targets do I keep? So I've divided this again into O2 and HFNO patients, NIV patients, ventilated prone patients, and those with acute brain injury. And you might keep lower targets. Usually less is more in the ventilated ones, in the HFNO ones, in the NIV ones, but definitely higher targets if there is associated brain injury. ECMO is the final rescue therapy, and VV-ECMO is believed to improve the oxygenation, reduce tissue hypoxia, it reduces ventilator-induced lung injury, and it can definitely stabilize the patient until maybe a transplant or the ARDS improves. The indications of ECMO, I cannot go into details, but they have a Murray score which looks into PF ratio, X-ray chest, PEEP, and compliance, and they have looked at various factors for ECMO indications in ARDS. We had the Caesar trial, in which they transferred the patients to the ECMO capable centers or managed them with routine care, and they did not find a major difference. In fact, the survival without severe disability was higher only in the ECMO group when they were transferred to a particular center. So it does not mean that you can always do ECMO in certain resource limited or knowledge limited settings. Then the EOLA trial came in, and there was a crossover also allowed, and here there was no non-statistical significant reduction in the mortality seen in the ECMO group, though there was a little benefit. Then they did a meta-analysis of all this and a systemic review, and they said that yes, ECMO, VV-ECMO is useful, but the main usage of VV-ECMO happened in the H1N1 and the COVID times, and we know now that ARDS can be beautifully managed with VV-ECMO until transplant is available. So the ELSO guidelines basically say that if the mortality risk is 50% in the ARDS patient, you must consider ECMO, and if it is 80%, then you must be doing the ECMO in these patients if the PF ratio, despite all your ventilatory strategies, is less than 80 or 100. Now some literature here before I end in the next 5 minutes. Challenges in ARDS in 2023 with personalized therapy. This gives me a very beautiful chart, and you can use this as a summary. There is a standard of care, and then there are rescue strategies. Tidal volume should be less than should be 6 ml. PEEP should be kept low or high depending upon the type of ARDS, the stage of ARDS. Plateau pressures should be kept below 30 or 27 here. The driving pressure should be about 15. Transpulmonary pressure should also be seen, and the mechanical power, which can be kept below 12. Rescue therapies would include prone positioning, recruitment maneuvers, neuromuscular blockage agents, inhaled vasodilators, and ECMO. This is another very nice study recently published in the Clinical Medicine Journal, and here it is using all these parameters, and they have given guidelines from ATS, ESICM, strong evidence for recommendation on mechanical ventilation with low tidal volume, prone more than 12 hours, HFNO, HFO not to be used, it should be avoided, and so on and so forth. So I don't have time to go through all these, but these are there available on the site on Google. And then there is another ATS theory, paper which has come out in 2024. I would like to discuss this just in 2 slides here. They have made strong, conditional, and against recommendations, and they have categorized mild, moderate, and severe ARDS. And here they have said that strong recommendation is for lung protective and prone, high PEEP and steroids, VV-ECMO, and neuromuscular conditional depending on the patient, and then strong recommendation against the recruitment maneuvers and the HFOV. They have also talked about steroids, VV-ECMO, NMBAs, and high PEEP, where it is conditionally used, etc. So I will just bring about trials because we like to know. So in this one slide, you will get everything that you want to know about the trials. The low tidal volume and the plateau pressures, we had the ARDS net in 2000 and the ARMA also in 2000. Optimum PEEP came from ARMA, Express, LOVES, and alveoli. Recruitment maneuvers came from ART and then Farlap in 2019. Driving pressures and stress index came by Brochard and Massimo. Power of ventilation or mechanical power and respiratory rate came from Coppola and Costa. And then proning obviously was from Prosiva. So there can be a 10 rule where you look at the tidal volume, the plateau pressure. Sorry, I'm repeating, but that's what we need to do at the bedside, proning and so on and so forth. And now it has moved towards goal-directed mode of selection of ARDS, where if there is severe ARDS, what should you do? If there is a high respiratory effort, you need to sedate them, use paralytic agents. And if there is a failure to wean, what should you do? So they have divided the treatment or management of ARDS into 3 zones. One is the safety zone. First, you protect. Then you have a comfort zone where you look after the synchrony of the patient, avoid dyssynchrony and avoid the shearing forces, and then try to liberate and wean the patient off. And this is another evolution of management. They came from tidal volumes, plateau pressures, to individualizing the pressures, looking at the delta driving pressure. And then now in 2024, they've said dose response curve of VT, and the dose response and the stress index and the mechanical power should be used. So personalized treatment can be done, and you can use the POCUS to actually look into these patients and see whether there is excessive fluid or there is any complications that happen. And this is my principle in life. When everything fails, a good cup of coffee works. And latte for ARDS is something which I just found out today. And this is the latte concept. L for how will your patient look? A for how will you assess the patient? T, what are the tests that you might do? Another T for how will you treat this patient? Mechanical ventilation, non-ventilatory strategies. And then E, I would educate myself at every time from the patient and from the guidelines as to how to ventilate an ARDS well. So my final slide here on how do I do it? I've just made this pyramid from what I just spoke about. The first step is low tidal volume ventilation, and that would be 6 ml. I would keep the respiratory rate less than 30 to avoid the mechanical power or the changes. I would keep a plateau pressure less than 30. I would keep a PEEP, which is optimum. I would do recruitment maneuver only in some situations, but I'll be a little wary doing it. I might do proning if the PF ratio, I will always do proning, even if the PF ratio is slightly better, but I would do that because then my ventilatory strategies become easier. I might use NMBAs to reduce the patient's efforts if it is too much, and steroids controversial depending upon the fibroproliferative stage of the patient. I might use carbon dioxide removal, that is the ECMO, or I might do VV-ECMO if everything else has failed. And then I would try to wean at any step. But if that fails, I might use newer technologies like proportional assist ventilation or NAVA, which is neurally adjusted ventilator assist. And then finally, nothing works, then transplant. But more important than this pyramid is to monitor the patient clinically and for dyssynchrony, the graphics and the compliance. In any moment of decision, the best thing you can do is the right thing. The next best thing is the wrong thing. And the worst thing is you do not do anything. So I think this is a very nice statement to end my talk. You can take the man to the vent, but you can't make him breathe. And therefore ventilate early, yet ventilate soft so that the lungs get back to normal breathing without support. It's just my poem. Thank you, friends. I'm sorry if I have outshot my time. Thank you.
Thank you, Dr. Khusrav. I think that was an excellent presentation, and I don't think anybody has minded even if you overshot your time limit, because that was fantastic. Starting with the basic concepts of ARDS to how you treat ARDS as a critical care expert, and summarizing it so beautifully with what we need to do and what are the trials which we can go back and learn from, emphasizes how well you understand this concept and how easily and clinically you follow it in your day-to-day practice. So thank you so much, sir. Now I have an excellent panel who will take up a few questions which I have prepared for them, and then we will have all the questions from our audience as well. Without wasting any time, I'd like to introduce our senior most panelist today. That's Dr. G. Thilawati Madam. She is a diploma and an MD chest holder. She is an HOD and a senior consultant of respiratory, sleep and interventional pulmonology at the Vijaya Group of Hospitals in Chennai. Madam is a treasurer and co-founder of the Association of Women in Pulmonology, is the associate editor of the Book of Pulmonary Disorders in Women, has been a faculty at various national and state conferences of NAPCON and TAPCON, has been the member of the National Board of Sleep Medicine Fellowship, and has been awarded the Inspiring Respiratory Medicine by the Indian Chest Society. She has notable publications on rare lung diseases, including tracheal bronchosis, and a case of pulmonary myeloma camouflaged with an invasive pulmonary aspergillosis. Her community contributions also excel, including has conducted and faculty workshops in NIV, sleep medicine, lung function testing, and bronchoscopy. She is a passionate teacher with numerous students having been trained under her over the years, and as a part of a pre-asthma camp and respiratory awareness programs. Welcome, madam. Our next faculty member is Dr. Abhishek Tandon. Dr. Abhishek Tandon is an NBDM phage consultant. He is a consultant and in charge of the Division of Asthma Allergy at the Department of Respiratory and Sleep Medicine and Medanta, Lucknow. His achievements include a gold medal for securing the highest marks in the Department of Pulmonary Critical Care Medicine at AIIMS Jodhpur and for the highest marks in Respiratory Medicine at the PGIMS College at Rohtak. He has been the President Appreciation Award by the Lucknow Chapter of Indian Medical Association. He's received the prestigious ICS ERS Travel Grant for the year 2024, which is no small achievement, having received the award myself 5 years back, so fantastic. And at such a young age has already achieved 32 publications and has co-authored 2 book chapters. Welcome, Abhishek. It's an honor to have you. Our next faculty member is Dr. Sunita Agarwal, madam. She's an MD DM, MRCP and FSCM with a fellowship in interventional pulmonology, consultant and head at the Department of Pulmonary and Critical Care Medicine at Medipulse Hospital in Jodhpur. Madam has over 36 publications and is a member of ICS ERS ISDA and various national and international organizations, has been the author of the book of case-based learning of ABG analysis and the junior staff editor for the Annals of Medicine and Surgery. She has been a gold medalist in her DM, a best thesis award in her MD, the best oral presentation at the Regional Asia Women's Conference, which is fantastic. And she has designed and compiled a mobile app and trials on respiratory diseases that's called as Chest Post. Using technology and advancing medicine is something which she excels in, she should all learn from. So welcome, Dr. Agrawal. And our final panelist is Dr. Alisha Chaudhary. Dr. Alisha and myself share the same university where we've graduated, so it's a personal welcome to madam. She's her IDCCM, MD, IDSC and FSCM. She's a consultant of Department of Critical Care Pulmonary and Sleep Medicine at the SUM Ultimate Hospital at Bhubaneswar. She has been awarded the European Diploma in Critical Care Medicine, a fellowship in sleep medicine, the ICS IWLX Travel Grant in 2019, the Best Paper Award in national conferences and state conferences, has 25 publications in national and international journals and chapters in books, and the area of interest is mechanical ventilation, point of care ultrasound, sleep disorders and infectious disease, which is why she is such an important panelist for us today. So I welcome all of you all. I hope we have an enchanting discussion and I get to learn a lot of points from you all.
Before we move forward, I have been given the honor and privilege to introduce our esteemed moderator for today's evening, Dr. Avya Bansal. He is an MD, DND, FAPSR and MNAMS. He is a consultant pulmonologist and sleep disorders specialist at the Bombay Hospital and Medical Research Center. Also an honorary pulmonologist at the Mumbai Hospital, the Mumbai Police Hospital, beg your pardon. And he's also a consultant at the Lung Care Clinic at Bandra. He's received the very prestigious Ratan Tata Scholarship. He's the university topper in his MD. He's received the ICS ERS Travel Grant and also the Best Paper Award for the ERS conference, which was held in Madrid in the year 2019. He's had his training in ILD from Germany. He has 10 national and international publications. And his special interest includes OAD, OSA, and ILD. He was responsible for setting up the adult vaccination OPD at Bombay Hospital, and he's been bestowed the ET Times Now Inspiring Respiratory Specialist of India 2024. And we are very honored to have you here as the moderator for this panel discussion.
Thank you so much, Dr. Abhishek. You made me blush on our meeting. Thank you so much. That was really polite. Okay, so let's get down to business. I'm going to start and open the innings with Dr. 𝐀𝐯𝐿 madam. She is going to tell us about ARDS, and I'm sure all of us are going to learn. So, madam, let's start with the basics from you. Let's start with the definition of ARDS. Now, a lot of my questions have already been covered by Dr. Khoshraf Bajan, but I want our audience to understand and be reinforced with all these definitions, because our basics and understanding of the syndrome starts with the definition and goes forward. Treatment becomes simple once our basics and pathophysiology of the disease and syndrome are cleared. So, madam, what exactly is the updated definition of ARDS? Madam, you have to unmute yourself, please.
Sorry. Good evening, everybody. Thank you, the entire ICS team, my panelist, and the moderator for having me here. It's a real pleasure and privilege to be here. And after that brilliant talk, I think we need not stress so many points. He has told everything, but let it be an additional reinforcement of the definition. I think Sir has really covered very well. So it dates back to the Berlin definition, the old between 2017. I think we are following the Berlin definition, which states that we need to understand the Berlin definition. That is how we can improve on the global definition. So the Berlin definition is actually has 4 components. It's about timing. The first thing is about timing. There should be an insult to the lung which is less than 7 days old. So within a week of a known insult, and it should be acute onset respiratory symptoms. That is the first timing. The second one is either the chest X-ray or the CT scan should show bilateral opacities which are progressive, and the patient should be in respiratory failure, where they categorize the PaO2 FiO2 ratio between 100 to 200, 100, less than 100, based on all the PaO2 FiO2 ratio, mild, moderate, and severe category. And then the patient requires an invasive or a non-invasive mechanical ventilation with a PEEP of at least 5 centimeters, more than 5 centimeters, or a CPAP of 5 centimeters. This is the Berlin definition. So it is not that we have given up on the Berlin definition, but we have modified the Berlin definition to cover extra patients with ARDS. So what they said was, the first thing is, they said instead of, if you don't have a chest X-ray or a CT scan, you can also use an ultrasound to detect the B lines on the patient, and then you can say that this patient has ARDS based on that. And the second important change is, they said, okay, if you don't have, in a resource limited setting, you don't have the ABG to monitor, then you have a SpO2 to monitor, then you can calculate the SF ratio, which is equally a reliable surrogate marker of PF ratio. So that is one. And the third thing what they said was, using HFNO and NIV has not been addressed in the Berlin definition. They have improved to include, say, HFNC, who are needing patients on HFNO, who are reading more than 30 liters per minute, and who are hypoxemic. These patients also can be included. And it is also that somebody in a resource limited setting, where they have a high flow oxygen, say for the, say like 15 liters per minute, and their saturation is less than 85, they also can be labeled as ARDS. And from all these definitions, what did they come to a conclusion? There are 3 main categories of ARDS. One is intubated ARDS, the other is non-intubated ARDS, and the other component is resource limited settings ARDS. So that is what they have come to a conclusion. So the only thing is, the new global definition of ARDS, it's just a new addition to the Berlin definition. So Berlin definition lives on. So if you have an intubated ARDS, mild, moderate, severe category, then that fits into the Berlin definition. But in addition, they have included this non-intubated and the resource limited settings. So that is the modification they have done. So why is this so important definition? Because we all know that these patients, whoever is working in critical care, we know that these patients already existed, which the Berlin definition did not address. So if you use the new global definition, I think you'll be able to pick up the patients early and respond early and treat better. That is there. So that this is, ARDS has mortality of more than 60%, between 30 to 50% in some settings, in most studies. So it's a high mortality disease. So we need to address them early. That is how this definition helps in your clinical setting.
Thank you, madam. That was a very elaborate and precise definition. And I think you've summed it up beautifully. What is ARDS in a nutshell? Now, moving on to Dr. Tandon, we've understood what basically ARDS is. Now, tell me, it's such a dreaded complication. What are the causes? What is the etiology of ARDS?
So since times immemorial, we've been classifying ARDS into two parts, the direct injuries and the indirect injuries, or the pulmonary causes or the extrapulmonary causes. So in order to simplify my answer, I'll also be answering and listing down the causes accordingly. So the direct injuries are pneumonia, aspiration, smoke or toxic gas inhalation, embolism, a laceration or a contusion, and oxygen toxicity. Whereas the indirect causes are sepsis, trauma, pancreatitis, multiple blood transfusions, drug toxicity, and a high altitude exposure. So these were also touched upon by Sir in his talk very beautifully, and I see no point in retaliating it further.
Okay, so perfect. We have direct causes and indirect causes, and that's how we need to classify. Understanding the cause becomes very important because sometimes treating the underlying cause of ARDS itself is the main treatment for ARDS, because you've corrected the pancreatitis or the embolism. That itself will have a protective effect on the lung and minimize the ICU stay and improve the mortality. Now, Dr. Akhidawal, tell me the pathophysiology of ARDS and why is it so important? Once we understand the pathophysiology, it becomes easier for us to understand what mode of treatment has to be offered in the phase of ARDS. So, what is the pathophysiology of this syndrome?
Thank you, Dr. Avya. So, yes, very well said that if you understand the pathophysiology, you can treat the patient accordingly. So, ARDS, I'll be taking you through 3 phases of ARDS according to their pathophysiology so that you can plan the treatment accordingly. So, ARDS, as we know, is acute onset hypoxemia, and the basic pathophysiology that is happening is diffuse alveolar damage. So, what happens in phase 1, the exudative phase, there is a lot of inflammation going on. Because of the etiologies just listed by Dr. Abhishek, there is endothelial and epithelial injury. So there is alveolar capillary membrane damage. A lot of protein-rich fluid is coming into the alveolar spaces. There is neutrophil activation. There's a lot of cytokines coming here, and that leads to surfactant dysfunction, progressively leading to hypoxemia and shunting. This is usually seen for the first week, 0 to 7 days, which is followed by the proliferative phase, that is 7 to 14 days, where there is 2 cells, the type 2 cells, so which causes alveolar repair and tries to get the surfactant production coming. We also see fibroblast proliferation at this proliferative phase. There is persistent vacuum mismatch that we can see in this phase. The final phase is what we see after 2 weeks in severe cases, that if your lung has not undergone the repair mechanism properly, that is a fibrotic phase. But there is persistent proliferation, fibril proliferation, there is loss of alveolar surface area, and there is severe reduction in lung compliance. So this leads to the progression of ARDS into a fibrotic lung and leading to a chronic respiratory failure. So the key pathophysiological features that we need to understand is because of all this, there is happening hypoxemia, reduced lung compliance, increased pulmonary death space, hyperinflammation, and cytokine storm coming up.
Very well said, madam. The exudative, proliferative, and the fibrotic phases are our go-to areas because we need to understand when we diagnose ARDS what phase it is, because management is very typical. There's no point adding a steroid once the patient is already fibrotic and has no lung left. That's the time we need to consider alternate modes of treatment, and at the same time, we shouldn't wait before adding protective modes of ventilation in the early exudative and proliferative phase. Now, moving on to what Dr. Thilagavati madam has already said, Dr. Ch.K.𝐒, I wanted to emphasize more on the diagnostic criteria of the Berlin and the updated Kigali definition using the PF and the SpO2 to FiO2 ratio on the mild, moderate, severe ARDS. So, madam, please elaborate on this.
Sure. Thank you, Avya. Excellent talk, Khushraw sir, as usual. And thank you, ma'am, who has made my job actually very easy. So, I just need to sum it up right now. So, the thing is, if you're in a resource limited setting, you don't have an ABG machine, go for the SpO2 to FiO2 ratio, which is the Kigali modification, when your saturation is less than 97%. And if that ratio is less than 315, that gives you an idea, probably this patient is in ARDS. That's the first thing you can do. Then look at 2 things. Is the patient intubated or non-intubated? In case of a non-intubated patient, your patient can still be on an HFNO more than 30 liters of per minute flow. or an NIV of PEEP more than equal to 5. In that case also, you can go for the SpO2 FiO2 ratio or a P by F ratio, right? In an intubated patient, the same thing again. But the only thing is, how do we use this Kigali thing? We know the PF ratio that it's 200 to 300 is the mild, 100 to 200 is moderate, and less than 100 is severe. In the Kigali's definition, when you're using SpO2 by FiO2 ratio, it will be from 235 to 315, 148 to 235, and severe ARDS is less than 148. So first, when you see this patient, you want to diagnose ARDS after going through all the above points which the faculties have given. So you have an intubated or a non-intubated patient, and what mode the patient is on, what device the patient is on, and accordingly you proceed.
Fantastic. Now, the conventional definition and severity of ARDS was based on 100 to 200 as the PF ratio was started. We had above 200, 100 to 200 and less than 100. Now, just to add another point for our audience, that what basically is a normal PF ratio? A normal PF ratio is between 400 and 500. So that's the normal PaO2 divided by the 21% of air which is there in the environment. Hence, if you have a low PaO2 of say 80-85 divided by 21, you have a PF ratio of 400. So that is our cutoff. Most of us have a PF ratio of between 400 and 500, and that is why this becomes such a simple thing for us to understand and monitor the severity. Ventilatory and non-ventilatory patients can be monitored on the basis of the PF ratio and the SpO2 to FiO2 ratio. So thank you, Dr. Chaudhary. Now moving on to the master, Dr. Kushraf Bhajan sir, I want you to tell us that what are the common investigations which help us to diagnose ARDS. Suppose we have a patient who's not with any relative, who just walked into the casualty, we see his X-ray, he's got fleeting opacity. Now what do we do? How do we know this is ARDS, and how do we understand the possible cause in this patient, sir?
Yeah. So basically, as we have been discussing all through, we know that ARDS is a syndrome and not a disease. We also know that there are hundreds of causes which can actually lead to ARDS. So my investigations would be based on trying to know the cause which has caused it, and also the severity of the ARDS and the definition or the diagnosis. So I would do the routine CBCs, cultures to rule out sepsis or rule in sepsis. I would need to do a D-dimer to rule out embolism along with it. And then I would need an X-ray, of course, which would have bilateral shadows. I will have to do an ABG to actually know that this is ARDS and whether it's mild, moderate and severe. I might even look at the SpO2 till the ABG comes in and look at the new SF ratio. I will need a CT scan once I've stabilized the patient. So it's not only hunting for the cause and doing the labs, but its first thing is to stabilize this patient, take him over, get the oxygenation and the hemodynamics appropriate. Now, if I do a HRCT, then that will be pretty helpful, because it will not only tell me the diagnosis, but it will also rule out certain diagnoses which would mimic ARDS at this stage. It will tell me the stages of ARDS, and as Dr. Gattinoni had done, he used to increase and decrease the PEEP and actually see what effect it had on the scan. So the CT scans can definitely help me in ARDS. Along with it, the mimics, which is the diffuse alveolar hemorrhage, the eosinophilic pneumonias, the bad cases of inhalation injuries, and the list can go on. Cardiogenic pulmonary edema would definitely need to be ruled out, and I would do an echo for that. The echo and the POCUS would definitely work. A POCUS would tell me that there are too many B lines, then probably it's only cardiogenic or the early exudative phase of ARDS. If I know that it's an interstitial pattern and I echo, I will do not only for the diagnosis and ruling out a cardiac problem, but now we look at the right ventricular dysfunction, because we know that that increases the mortality. So I think it's a entire stabilization and investigations to try and move further in these patients.
Thank you, sir. I think you've summed it up well. This is what we do when we have a hypothetical patient, Mr. Kim Trump, who's a 60-year-old male who presents to a casualty with a bad X-ray. So this is how we investigate. Now, moving on to
Why did you choose Trump as the name?
Kim Trump.
I'm just kidding. Yeah. Okay. Go ahead.
So, madam, now we've got Kim Trump. You've been called by your resident doctor that this patient is on NRBM, he's hypoxic, he's breathless. I have diagnosed him to have ARDS. Now, what do we do next, madam? Before we wait for the reports to come, how do we manage this patient? The patient still is tachypneic on a non-NRBM breathing mass is at 90-91%. Now, is there any role for HFNO, and how would HFNO be beneficial in this case?
So this patient is clearly hypoxic. He's on NRBM and he's an ARDS patient, right? So what do we do? So before we switch from NRBM to the next HFNO, that's the next modality. If you have phenotyped the patient, there are patients where we go from NRBM to directly to ventilator. That is a different thing. So let's deal with HFNO patients. So I think the first thing you need to do is assess the severity of hypoxemia. Whether this patient, you calculate the PaO2 FiO2 ratio, whether this patient belongs to the severe ARDS category or mild, moderate, whatever, depending on the ratio, and also look for worsening respiratory failure symptoms. If your patient is having increased work of breathing, altered mental status, he may not be very comfortable with HFNO. And also look at the ABG for respiratory and metabolic acidosis, hemodynamic stability. I think you need a lot of factors. You need to look at the patient as a whole. If the patient is hypercapnic and he has persistent SpO2 less than 90%, even on NRBM, all these things, the next step, I think there is a role for high flow nasal oxygen. But according to ATS and the European and the, I think, Critical Care Society, so HFNO is recommended over NRBM in patients with ARDS who have moderate hypoxemia, not for severe ARDS. That we should remember. So, and who can also maintain spontaneous breathing. So HFNO, it can deliver up to maybe 100% FiO2 with heated humidification. It has a lot of benefits, like it decreases the work of breathing and it reduces the dead space. It can improve the oxygenation, but don't forget that it comes with, if the patient is not cooperative, is not mentally stable, or he is very, very too sick, his respiratory rate is, the work of breathing is very high, then I think HFNO is not the ideal choice. So if HFNO, the most important thing is, if HFNO is not suitable, patient is rapidly deteriorating, don't go on continuing HFNO for a long time. To assess whether this patient is okay, fit for HFNO, you can try it for some time. The key parameter, the guideline stresses using the ROX index, that is SpO2, FiO2 and to the respiratory rate ratio. So use the ROX index. If the ROX index is less than 2.8 for a period of time, say 2 to 6 hours, then I think he is in a candidate for intubation. The most important thing when you put a patient on HFNO is you need to identify patients who are not fit for HFNO and need intubation at the earliest. Don't delay the HFNO and don't delay the intubation. So that is the most important, which is main reason for mortality. So in summary, look at hypoxic status, look at if moderate ARDS, go for HFNO. If severe ARDS, don't at all attempt HFNO, go straight away for intubation, and always closely monitor the ROX index if patient is of HFNO.
Also, I think it's very important to understand and assess the consciousness of the patient, because that's the first step. If the patient is losing consciousness or is a bit drowsy, even though on the NRBM, I may not consider HFNO at that point of time. Also, the baseline CO2 levels of the patient become very important, because sometimes these patients may have an underlying respiratory disorder such as COPD, which may be missed. And at that point of time, HFNO has to be used with caution. Another point which I want to add for our audience is that when Dr. Kushraf mentioned POCUS is point of care ultrasound for those who don't know. And that is something which we'll be discussing later. Now, moving on to Dr. Abhishek. Now, Dr. Abhishek, Dr. 𝐀𝐑𝐃𝐒 madam has managed this patient of HFNO and you've been called in as a second opinion. This patient is still breathless. He's not maintaining of HFNO. Now, what would you want to proceed? He's moved on to a moderate to severe kind of an ARDS where it's bordering around 80 to 150 PF ratio. How does NIV help in this patient? What would be your settings on the NIV? And when would you consider that NIV is not working?
To be very honest, if a patient is in a moderate to severe ARDS, I will not be very comfortable in giving a trial of NIV to that particular patient. This point has also been reiterated by Dr. Bajan in his slides, and he said that NIV in ARDS is only indicated for patients who have a mild variant of an ARDS and who fulfills all the criteria that Dr. Gurumurthy just listed. The patient has to be conscious, oriented, hemodynamically stable, and the work of breathing should be fine. Having said that, I would want to talk about very briefly 4 trials that have been done for NIV in ARDS. Again, they had been spoken to about by Dr. Bajan in his slides, but I would want to make a very brief comment. NIV was compared with Venturi. NIV fared better. NIV was paired with HFNC and it showed that it did not fare better. the interface was compared, helmet versus non-helmet, and it said that the helmet interface fared better. And again, when we phenotype ARDS into pulmonary and the extrapulmonary causes, NIV in the extrapulmonary causes fared better as compared to the pulmonary causes. So the evidence is very conflicting. And if you ask me what my practice is, in mild ARDS, yes, when it proceeds into a moderate or a severe ARDS, if and only that the patient is not giving me a consent to put, the attendants are not giving me a consent to put the patient on a ventilator, will I ever choose a NIV? Otherwise, I'll directly intubate and put them on a IMV.
You know, it's a very good answer. And the reason I asked you this question is because a lot of us hesitate to intubate the patient. And we have a stepwise approach, O2, NRBF, HFNO, NIV. So it's a clear message which the audience needs to take back home. Mild ARDS, use your modality, NRBM, HFNO, NIV, whatever it is. But the minute you have a moderate ARDS, please counsel the family that this is the best chance you're going to give them. And an early versus late intubation is always going to be beneficial, which is why the next question in the sequence is Dr. Agarwal, that why is early intubation more important than late intubation in ARDS patients, and why should moderate patients itself be intubated? Can you please tell us and educate our audience even more that NIV is not the solution for moderate and severe ARDS?
Right. So since we have been discussing since quite a while about early versus late intubation, I think this is one of the most difficult questions for an intensivist really. And especially like see earlier, I think in Marino there was a line that if you're thinking of intubation, just intubate the patient. But now since we know that it causes lung injury, we have seen so many VAPs, and so we are a little precautionary about intubating such patients. And then especially after COVID, we have been a little bit hesitant, about early intubation. Having said that, as we said, let's make it very simple. There are absolute indications where you're going to intubate your patient. That is when you said altered sensorium, hemodynamic unstable patient, or if your patient is having a refractory hypoxemia, that is a PF ratio is less than 100 despite optimal settings on your NIV, or if the patient is in respiratory distress. So if your respiratory rate is more than 35 per minute, or if the patient is having a paradoxical breathing, patient is using accessory muscles of breathing on NIV, yes, this patient needs to get intubated. Now comes to the picture where you don't have these signs, but the patient is still having a moderate ARDS. What do you do in such cases? So what are the benefits of an early intubation? You are delaying the rescue intubation for the patient. You are preventing the patient's self-inflicted lung injury and the excessive inspiratory effort that a patient is taking. And as compared to that, late intubation, basically why are we preventing intubation is because we are expecting the ventilator-induced lung injury or ventilator-associated pneumonia. So we know the precaution that we need to take for such patients. Now, standard trials have been done. The lung safe study, which showed that there is increased mortality in moderate to severe ARDS if you continue these patients on NIV. Even the Florali trial had told that if you continue these patients on NIV, there is an increase in mortality. Now, having said all these things, knowing the indications and contraindication benefits and the harm that you're going to cause a patient in early versus late, it is important that you personalize the patient. You see what the patient is going through. So if your patient is responding well to NIV in terms of benefit in hypoxemia, the respiratory muscle of breathing is less, the parameters are improving, your pulse rate, your respiratory rate, oxygenation, BP, they are all improving, patient is sensorium wise improving, then you continue this patient in NIV. But during this monitoring, if you are finding any of these parameters going down, you should consider intubating this patient and start counseling the relatives about it.
The take-home message from what Madam just said is a reiteration of what Dr. Bhajan said: intubate early, intubate soft. So intubate soft, so you prevent those injuries to the patient, but don't be afraid and don't be scared to intubate your moderate patients. I agree with Dr. Tandon and Dr. Agarwal in this, that for me, my threshold is a moderate ARDS. The minute I see a moderate ARDS, I'm going to wait for a couple of hours. If my change of settings don't help the patient, I'm going to aggressively ventilate the patient because that's the best possible option to prevent a mortality. Now, Madam, this patient has been intubated.
Quick comment.
Yes,
yeah. So basically this NIV thing, you very nicely said that you want to go through HFNO, NIV, and then if that fails, you go to intubation. But you must bite the bullet and let the patient bite the endotracheal tube because it should be done early. Only if it is a cause of ARDS is something which is reversible. If it was dengue causing it, or if it was some other cause like trally, and in 2-3 days it is mild and it is going to reverse back, then maybe NIV. But otherwise, Otherwise, definitely NIV is not the way to treat a patient with moderate to severe ARDS.
And which is why I wanted all the panelists to reinforce the same point so that the audience takes back this important message that early intubation is the key in moderate ARDS. Now, Dr. Chaudhary, this patient has been intubated. Now, how do we ventilate soft? Why is 𝐕LI and P-SILI so important in these patients? Can you please tell us?
So, the beauty about ARDS concepts is most of the terms are self-explanatory, right? So, we thought let's intubate the patient, biting the tube is better, but that comes at a cost. Nothing in life comes for free. So, that's why 𝐕LI, which is ventilator-induced lung injury. So, basically, you are actually blaming the ventilator, which is a main culprit, which is causing all the adverse effects in the patient. It is actually a very umbrella term, right? There are a lot of, subcategories in it. You can have volume trauma because of this ventilation when you are not very careful about your tidal volumes. You can have barotrauma because of raised pressure, because of the repeated, closing and opening of the collapsed alveoli. It can lead to release of a lot of inflammatory mediators, which is called as like biotrauma. There can be even atelectotrauma because of repeated opening of this collapsed alveoli, and the newer concept evolving, the ergotrauma, which is secondary to the energy load which is being delivered by the ventilator to the patient. And oxygen toxicity when you're not careful about your FiO2 targets. So, you can cause a lot of absorption atelectasis. When I mentioned P-SILI, P-SILI is patient self-inflicted lung injury. Again, a self-explanatory term. So, the patient is responsible now. What is happening over here is there are like vigorous inspiratory efforts, right, in a spontaneously breathing patient. So, because of which there are large transpulmonary pressure swings. What is the transpulmonary pressure? So, difference between your alveolar pressure and the pleural pressure. Now, to deliver a certain amount of volume into the lungs by the ventilator or by this patient, when they take this, vigorous inspiratory efforts, the pressure range is going to be very variable on a lung which is already very diseased. So, this variation of pressure can cause a lot of damage to the lung. The pendulum effect, which Khusrao sir had mentioned at that point of time, is because of the movement, back and forth of this air from the non-dependent regions to the dependent regions, causing even more lung injury. Also, because of this vigorous inspiratory efforts, there's a lot of negative intrathoracic pressure generated that can lead to a lot of increased venous return, which finally causes, more and more lung edema. You can have diaphragmatic dysfunction because of all this inspiratory effort. Your diaphragmatic muscle fibers are getting contracted, and finally a lot of patient ventilator asynchrony. So this needs to be also looked after and managed properly.
Excellent. Very well said. Don't intubate the patient, give rise to P-SILI. Intubate the patient, give rise to 𝐕LI. So intubate early, intubate soft remains the standard. I'm going to keep repeating this. Now, madam, the patient is on intubated. He has been on lung protective ventilation. The patient is worsening. What is the role of the magical drug steroid in these patients? What are the indications of steroids, and what is the dose, and what's the preferred steroid?
I think this most controversial topic where all the guidelines.
Sorry, ma'am. I'm sorry. I want to, before I take that topic up with you, I want Dr. Khusrao to tell me that what lung protective ventilation is and what are the key values which we look at before we move on to the steroid thing. I missed asking him that question. I'm sorry about that.
Yeah. So two concepts before I answer that. Ventilation is not a therapy. Ventilation is only a supportive mode. So you must do no harm. So 𝐕LI should not happen when you ventilate somebody with ARDS. The lungs are already injured. You cannot injure them further. The second thing is when you are coughing or when you, play the trumpet, your peak pressures can go up to 200. But you don't get a barotrauma. So the movement, the understanding of 𝐕LI, as beautifully explained by Alisha, is moving from barotrauma to volutrauma to ergotrauma to shearing forces. Having this in mind, we have 6 parameters which we can look at in trying to do lung protective strategy where we are avoiding the 𝐕LI and improving the outcome. So the first is tidal volume, which we must keep it low at 6 ml per kg of predicted body weight. That's important. We need to have a predicted body weight calculated. We need to do a plateau pressure of less than 30 because that is the compliance of the patient. We need a driving pressure, which is plateau minus PEEP of less than 15. We need the mechanical pressure if you are monitoring less than 12, and you can prone these patients early to almost get a better better VQ matching and perfusion and ventilation happening to the dependent and the non-dependent areas to try and do a lung protective way. If none of this works, then you might have to do ultra lung protection where you go to 4 ml per kg, and that you can do along with ECMO. Having done this, you need to monitor a lot of things. You need to add PEEP. That is because of the baby lung concept, and you need to keep the alveoli open. So it is not part of lung protective, but it is part of opening up the alveoli. You may do a rescue strategy like recruitment maneuver, but you might want to sedate them. You need to paralyze them definitely for a certain amount of time if their efforts are too high. And if one more thing, a permissive hypercapnia may be allowed, but beyond a certain level, you might need to do echo to try and remove the carbon dioxide. So I think this is a strategy that I would do to try and protect the lungs from further ventilatory damage.
We've all learned about how to ventilate the patient. We need to ventilate early. As soon as possible, when we see moderate ARDS, we need to be cautious and mindful of ventilator-associated injury. And we need to follow a concept of lung protective ventilation. Having done the basic principles, now how do we treat medically? So coming back to madam, where I missed sir, is the role of steroids in ARDS, the indication, dose and duration. Ma'am, unmute yourself, please. Sorry.
Yeah. So I think this is the most controversial in all the, the critical care society and IDCCM, SCCCM and our ATS, ERS, everywhere. There is a big controversial regarding the dose, regarding the indication, regarding the type of steroid, how long to give, what to give, everything is a controversial. And I think it is fair enough because these patients are very, very heterogeneous. As sir said in his presentation, you can see the various causes, how they behave. Each one has a different trajectory. Each one has a different problems. So I think we need to be very, very careful in giving steroids and not to deprive steroids to the right patients also. So as far as steroids are concerned, it is not for very mild ARDS. The first concept is don't use it in mild ARDS. It is only in moderate to severe ARDS on a case-by-case basis. The most important thing is don't start late also. You have to start it early, within 7 days. That is in the early proliferative phase, exudative phase. Do not go to the fibrotic phase and things like that. And the third and the fourth important point which you have to see is most of these patients in our Indian ICUs have diabetes. So we have to balance the steroid with the hyperglycemia. That is the most important thing. And the next important point in giving steroids is most of our ICUs with ARDS are 80 to 90% of the time due to infections. So there again, you need to balance between your steroid dose and your infections. If your patient is severely sick, then you have to balance the dose. So there is no one size fits all. Now the problem with giving the type of steroid, most guidelines, there is strongest recommendation for dexamethasone, but there is also recommendation from from the recovery trial and the other trials that dexa works well, and there is a Meduri trial where methylprednisolone is better. So ATS says methylprednisolone, the intensive care guidelines, all of them favor dexamethasone. And I think here we need to be very, very clear as pulmonologists that each steroid has its own effect and has its own glucocorticoid and mineralocorticoid effect and has its own duration of action. If your patient is terribly sick in sepsis and you're going to throw dexamethasone on that patient who has, he has a terrible sepsis, and then you give methylprednisolone, you give dexamethasone, it has got action for 2 to 3 days. You can't even restrict, the next day the patient is in severe sepsis, you will not be able to reduce the dose or prevent the damage, and you will have further damage. And also methylprednisolone is something in between. I think between dexamethasone is a potent glucocorticoid, has long duration of action. Hydrocortisone has equal effect of mineralocorticoid and glucocorticoid and has short duration of action. Depending on the type of your patient, you need to choose the steroids. And the dose is also the same. If you have hyperglycemia, and it's very labile in a day, you cannot fix the dose of steroids. In a day itself, you will have so many issues like hyperglycemic patients, you will want to reduce, and the sepsis is progressing very badly, then you again want to reduce the dose. So benefit versus risk ratio. The other important point is phenotype the patients on whom you are going to give steroids, as this is a heterogeneous disease. So you have a hyperinflammatory ARDS is one category, hypoinflammatory is one category, you have pulmonary ARDS, you have extrapulmonary ARDS, you have different categories. So I think that also needs to be considered, and then you have to decide how to give the steroids. Such a big topic. I don't know. I think you should have a good clinical acumen, putting everything together, and it's not one size fits all, and it cannot be a fixed dose on one day. Depending on what your patient is, you can choose the steroid and you can follow the dosage also.
I think very well said. Now, for our audience, what they need to understand is choose a good steroid with the least mineralocorticoid activity. What that basically means is you need to ensure that your water, sodium, and potassium are in check. That is what the mineralocorticoid activity of the steroid does. You need the steroids in ARDS for the anti-inflammatory effect. So probably the critical care physicians prefer dexamethasone because it's the most potent anti-inflammatory effect. Pulmonologists may prefer methylprednisolone because of the penetration of the lung. So there is always a fight between dexa and methyl, but I say if you have the equivalent dose of both the steroids, they both work well. Dexamethasone probably is preferred more because the intensivists see more non-respiratory ARDS as well as the primary cause, whereas pulmonologists see more respiratory causes of ARDS. Maybe that's why they prefer methylpred. But the dose is very important. So we've seen that about 2 mg per kg.
One more point is, if there is sepsis and septic shock, then without the extrapulmonary ARDS, I think you can go for hydrocortisone as the intensivist suggests. So if you have other type of this thing, when you want the BP to be more, when you're already on inotropes, I think there you can give hydrocortisone. The rest of the time we have to choose between dexa and methylprednisolone.
Yes. So for surviving sepsis guidelines and for septic shock, hydrocortisone is the drug of choice. But in cases of ARDS, we prefer dexamethasone or methylprednisolone at the equivalent dose, tapered gradually. Yes. Now moving on to Dr. Tandon. Dr. Tandon, a very important concept, and I need a valuable insight on this, is the role of prone ventilation in ARDS. Why is it so important? Why is early prone ventilation important? What is the duration of prone ventilation? And the devil's advocate, what are the complications and the negative aspects of prone ventilation in these patients?
Like you said, Dr. Bansal, it's indeed a very valuable question. When a patient presents to me and the patient is intubated and the patient is not maintaining his or her saturation despite the low volume tidal ventilation that we deliver to the patients, the norm should be don't wait and prone early. Through the landmark PROSEVA trial, we now have enough evidence and also the various trials that followed. It says that we should not wait for the ARDS to travel from the exudative phase to the fibrotic phase and then prone, because proning has shown its maximum benefit and the early ARDS phase. So as early as 36 hours, the patient should be prone. To answer your question, what should be the duration of proning? A minimum of 16 hours. This is what we follow at our center. For how long should we prone? We generally prone till the patient fulfills the criteria for us to stop proning. For us, the criteria is if the patient has a PaO2 ratio of more than equal to 150 for more than equal to 4 hours after the last session of proning was terminated. The PEEP here should be less than equal to 10 and the FiO2 here should be less than equal to 0.6. Having said that, in the PROSEVA trial, they had prone patients for up to 28 days. Now, coming on to the benefits of it, I guess this was very beautifully elaborated by Dr. Bajan in his slides, where he explained the exact pathophysiology of how proning a patient helps. There are certain contraindications of proning, the most absolute of which is a patient who has a spinal cord instability or a patient who has certain fractures which limit us from giving him a position what the prone position mandates. As far as the complications are concerned, the most common complications that we encounter, or I have encountered both as a resident and now as a consultant, is that during the procedure of proning a patient, we have seen dislodgement of the tubes, we've seen dislodgement of the lines. Certain times the patients, once you prone them, they don't maintain their tidal volume and they develop a type 2 respiratory failure. Certain times what happens is that they develop a shock, and these are certain indicators that you have to immediately stop with the proning cycle, and you have to make them assume a supine position. I guess that's all from my side as far as proning is concerned. Due to the lack of time, will not elaborate further. But yeah, I guess I've answered all the questions that were asked.
Absolutely. And another modality which comes so importantly, which Dr. Chaudhary practices a lot, is focus. Focus becomes very important when we prone our patient. So that's something which we need to keep in mind, where point of care ultrasound is extremely important. Now moving to Dr. Agrawal. Madam, what is the role of neuromuscular blockade? Like we've seen, Dr. Bhajan told us that there has not been consensus because of infighting between societies on the concept of neuromuscular blockade, the concept of sedation. So in which patients do we consider neuromuscular blockade? What are the advantages? What would be your preferred agent of neuromuscular blockade, and how long would you keep the patient paralyzed?
Right. So, considering that there is so much of controversy behind it, I think it's important to understand that you want to prevent ventilator-induced lung injury and you want to ensure protective lung ventilation. So, for this thing, basically for these two aims is when you are going to have your paralytic agent working, because you want to take control of the ventilation now to prevent these two things and to achieve protective ventilation. So when are you going to have a challenge in achieving this? It's going to be mostly in cases of moderate to severe ARDS, where patient is having dysentery with the ventilator. You are expecting that there is a barotrauma going on, plateau pressures are not maintaining where you want to maintain it less than 30. So these are the patients where you will use. When will you use? You have to use it early, like within the first 48 hours of your ARDS developing in, because there is no point of, protecting the ventilation once the patient has gone into the fibrotic phase or in the proliferative phase. Early use is important. Role is to prevent your ventilator-induced lung injury, to prevent your patient-induced self-inflicted lung injury, ensure protective ventilation. And also the ACURUS trial has shown that it causes some amount of anti-inflammatory action. So that is one of the other results that they saw. And so the agent of choice is the third question. So you want an agent which is not acting for a very long time, because prolonged use of neuromuscular blocking agent is going to cause critical illness, neuropathy and myopathy. So you want an agent acting less for a lesser duration, and also having not affecting your other organ, that is liver or kidney. So cisacatacurium was a drug of choice which is used in other trials also due to Hoffman elimination. So it has a faster elimination than other drugs. So the two trials that were standardly done for neuromuscular blocking agent, first one was the ACURUS trial done in 2010, where they used the cisacatacurium and they showed that there is definitely mortality benefit. But this was not replicated in the ROSE trial done in 2019. Again, having said that, the subsequent systematic review meta-analysis has shown a benefit of using neuromuscular blocking agent in this criteria of patients where you're having moderate to severe ARDS with ventilator-induced lung injury, or a patient having dysrhythmically with the ventilation. So and how long will you use it? Well, you use it, usually the use will be restricted to the next 48 hours, because subsequently your patient is going to respond to your therapy, and then you will have to stop the neuromuscular blocking agent to prevent your critical illness, neuropathy and myopathy. Right. So another thing is to avoid using in patients with mild ARDS. So if your patient is maintaining lung protective ventilation on your mild sedation, then you don't have to go ahead with your paralytic agents. Right.
I think understanding the concept of controlled ventilation when it is required, that is when neuromuscular blockade does come in the first 48 hours, where we need to ensure that what we are giving the patient on the ventilator is being delivered. And we don't want any P-SILI in cases of moderate or severe ARDS. So very well said, madam. Point well taken. Now, moving on to Dr. Chaudhary. Madam, what is the concept of open lung ventilation strategy? And what is the role of high PEEP? We've spoken so much about PEEP in ARDS, auto PEEP, intrinsic PEEP. So why is PEEP so important, and why high PEEP in ARDS?
So when we talk about open lung ventilation, it's basically application of PEEP with the low tidal volume ventilation. But this comes actually after Kushrao sir has put the patient on low tidal volume ventilation and before Abhishek goes for proning. So I come in between over there. So basically, you are giving PEEP, which is positive end expiratory pressure, the point of which is the non-dependent alveoli which are collapsed. You want to open them up. You want to make sure you're not causing a lot of atelectotrauma or biotrauma. You want to ensure maximum recruitment of those alveoli, because those are the alveoli according to the baby lung concept which are not getting ventilated at all. So if you look at that way, you will think, why not put a higher PEEP so that I can open more and more alveoli? So that is why there were three great trials in 2004 and 2008, which were named by Alveoli, Love and Express. All these were very classic trials which looked at higher PEEP versus lower PEEP. Though few of the trials found that, okay, higher PEEP did fare better, but when it came to replicate, to a mortality benefit, that couldn't be shown, though it reduced like a lesser chance of proning, a less ventilator days and all. But finally, Briel et al. In 2010 did a meta-analysis of all these three trials. He took all those 3,000 patients and studied them closely. And in a subgroup analysis, he found that moderate to severe ARDS patients actually did better with the higher PEEP, not the mild ARDS patient. So that is why the high PEEP concept came. But over the years and with COVID, it's no more called higher PEEP right now. What we talk about is the optimal PEEP. We have to make sure our alveoli are well recruited. Plus, we are not distending them to cause, a lot of barotrauma or volutrauma. For that is why we do, PEEP titration bedside to look for that optimal PEEP. So you use your PEEP FiO2 table given by ARDS ARDSNet trial, which is like published. Or the second thing which we commonly follow is incremental or decremental PEEP titration. Meanwhile, you monitor at every PEEP setting, you put what is the compliance, what is your plateau pressure, and what is your driving pressure, and find the best PEEP. Use of ultrasound to know, when you put a PEEP, whether the lung is getting aerated or de-aerated, and some theoretical things like, pressure volume loops, because it's actually not so easy to do it. You need a lot of expertise for that. Or esophageal manometry, which is upcoming, sadly not there in my hospital, where you can actually monitor pleural pressures and transpulmonary pressures and get that optimal PEEP.
Fantastic. That's very well said about the concept of recruitment and why PEEP is so important in ARDS. Now, I'm going to skip and I'm going to ask Dr. Abhishek Tandon that what is the concept of permissive hypercapnia and why pH and PCO2 are so important, and what is the level of PCO2 which is acceptable in our patients of ARDS?
So we've been talking about how we need to prevent ventilator-induced lung injury in patients of ARDS. So the concept of permissive hypercapnia comes in precisely for that particular concept. So what happens is that in order to deliver a low tidal volume ventilation, you are allowing the patient to take in shallow breaths. As a result of the hyperventilation, the carbon dioxide can go up. Now, this can be acceptable to a certain extent. For example, in the ARDS-NET protocol, we have been told that the ideal pH should be somewhere between 7.30 to 7.45. But having said that, you can go up till a pH of 7.15 to 7.30 as well. And if that is happening, what you can do is that you can increase the respiratory rate to an extent where the maximum respiratory rate can either reach up to 35 or the PaCO2 can come down to a minimum of 25. If the pH goes down further, that is below 7.15, you can first increase the tidal volume by 1 ml per kg body predicted weight. Even if the pH is less than 7.15, then there comes a role of an IV bicarbonate here. So permissive hypercapnia to a certain extent is okay, but once the pH starts going somewhere below 7.15 is where we need to increase the tidal volume and maintain the carbon dioxide in a permissible range.
Okay, so basically what permissive hypercapnia means is that we are allowing perfusion to set in and there's no ventilation, and we are okay with that. We are okay to have a high PCO2 at the expense of having a sustained good low tidal volume ventilation. So we must not be worried, because as pulmonologists, we have a CO2, our eye is there on the CO2. We don't want a CO2 going up. Whatever may be the underlying cause of the ARDS, understand that a permissive hypercapnia, a 55-60 PCO2 can fluctuate, is acceptable. Keep an eye on the pH. That is where pH becomes so important in managing these patients. So very well said, Dr. Tandon. Now I'm going to ask Dr. Kushraf sir that what is prolonged prolonged recruitment, and how does recruitment help these patients of ARDS, and should we actually consider high frequency oscillatory ventilation, and why was it discarded in the upcoming data and literature by the ATS?
So there are two questions on this. Both are usually rescue therapies, but recruitment maneuver definitely is a rescue therapy when everything else is done and the patient is not doing well. Or you could do a RM, which is recruitment maneuver upfront, and you might actually know that which patients have a recruitable lung or non-recruitable lung, or responder versus non-responder, and then you might be able to titrate your PEEP in these patients and give this patient, the responder, a higher PEEP, etc. So this is the same as the phenotyping that we might want to do. So there was a study called the ART study, which is the alveolar recruitment trial, and there they used recruitment maneuver along with high PEEP, and what they did is about 30 to 40 centimeters of pressure, that is the PEEP, was kept for about 30 to 40 seconds. And that would help to improve the alveoli or not improve the alveoli. This study definitely showed increase in the mortality. Or you can do different stepwise PEEP, and you can increase it to 10, then 20, then 30, then 40, and you can't go beyond 30 seconds to 1 minute, and that's how you can actually do your recruitment. The improvement that you look for, or the monitoring that you do, is to whether the saturations have improved, whether the tidal volume delivered is now better at the same amount of pressures, the compliance has gone down, etc. The problem here is when you increase recruitment maneuvers, you are actually increasing a lot of intrathoracic pressure. So there is a chance of hemodynamic instability as well. So, but as far as the studies are concerned, recruitment maneuvers are to be taken with a pinch of salt. Coming to the question on HFOV, I don't see much of a role of this mode. It can be used mainly as a rescue. We had the Oscillate trial, which showed no benefit. We had the Oscar trial, which said do not use it, but we still definitely use it. I only see one point where I might use it if this patient has developed a pneumothorax after ARDS ventilation and has developed an air leak or a bronchopleural fistula. So this is one case where I might use high frequency oscillation. It's actually quite a very noisy machine. We give a respiratory rate of almost 60, and I always feel, oh, put the patient on HFNO is same like putting the patient on a washing machine. So the same sound it makes, and it's annoying to all the other patients. So maybe you might do it when you are not on duty, but it doesn't have much benefit, but it definitely takes your mind away from looking after other patients because of the noise and the other things.
And it scares the other patients. So HFVO should be used only in expert hands, and someone who's not experienced with it should not be used, which is why probably the ATS is so skeptical about it and has said conditionally, don't use it. Yes. Stay away from it.
The only use I see is in pediatric age group, where it is used pretty much more than in adults.
Pediatric group, actually.
Yes, Ali.
For the IRDS, not the ARDS aspect of that. Okay. Nice.
I remember one patient where the patient, 5-year-old kid with ARDS, was on high frequency oscillation. The patient was actually moving, and the patient was also on ECMO, and I was called in to do a tracheostomy. Imagine my plight. So I actually had to do the tracheostomy moving with the patient with every oscillation. I had to be careful, and I was thankfully successful, luckily. So I cannot forget that HFO with ECMO where I was called in to do a tracheostomy.
Life teaches us weird things into operating difficult situations. So, moving on to Dr. Agrawal. Madam, now we've done all of these things for our patients. How do we monitor them? What is the role of serial ABG, serial X-ray, and the importance of POCUS or ultrasound, which is such a simple, inexpensive tool and yet seldom used in most of the ICUs in today's practice?
Right. So let's take it one by one. First of all, role of ABG. I mean, when will you do it? So first of all, diagnosis. I mean, ARDS definition itself says that you need to have a PF ratio less than 300. So you will do it for your diagnosis. Then we have certain ventilatory criteria. So we want to target PO2, we want to target saturation, we want to target plateau pressures. So to achieve those targets, you will be doing your ABGs whenever you're doing a change in the ventilator settings. Third, you want to see the PaCO2 and you want to see the pH, because we are discussing the terms of permissive hypercapnia. So how much CO2 are we actually allowing the patient to have, and what is the pH that we want to let the patient take. So these are the conditions and the settings where you will be doing your ABGs. Next, move on to the X-ray. So again, diagnosis of ARDS requires your X-ray, because the definition itself says bilateral lung infiltrates. Having said that, X-ray also helps us in ruling out the other diagnoses like your pneumothorax, atelectasis, bronchiectasis, and cardiogenic pulmonary edema. So those kind of things. How often will you do it? So in your ARDS patients, initially you would do it every day, so that you can monitor your settings of the ventilator change, whether your ventilator change has caused any complication like barotrauma, pneumothorax, or there is new development of cardiogenic pulmonary edema, or there is some other infection that is taking place. Then if you have done any intervention like a central line or a tracheostomy, in those cases again you would like to do an X-ray and see what is the actual picture, where is your line going, where is your tracheostomy. If you have re-intubated the patient or something, again you would like to do an X-ray. In weaning also, when you're weaning your patient, you would want to see whether there is improvement in your X-ray as well. So those cases also you will do an X-ray. Third, and the most important discussion that you want to do is about the lung ultrasound. So now lung ultrasound is a bedside technique. It gives you real-time imaging. It doesn't have radiation. So those are the three benefits that your ultrasound gives us, and it gives you the same answer that your X-ray or your CT scan may give you. First of all, in diagnosing, so you will see B lines, but those B lines you will say is also seen in cardiogenic pulmonary edema, but the lines are different. In cardiogenic pulmonary, there are uniform lines seen throughout the lungs. But if you have those ununiform lines not distributed in a uniform pattern, you know that you are seeing ARDS. Then you would rule out other causes as well. So if your lung slide is absent, you know this is not a pneumothorax, but you're dealing with a non-cardiogenic pulmonary edema. So it helps in your diagnosis. Then it also rules out, if there is consolidation in the earlier phase, so your C lines or those C pattern that you see in ultrasound, then you know that this is a pneumonia that we are dealing with. Apart from that, it also helps in your managing part. That is, it guides your PEEP titration. So when you've increased your PEEP, you need to know that whether you've given adequate PEEP or not. So if your PEEP is on a higher side, you will again see that lung sliding coming in, or your A lines will start, coming in. So you can see the over lung distension that is happening with your ultrasound. Then if your patient is on prolonged ventilation, they usually develop diaphragmatic dysfunction because less use of the diaphragm. Even your neuromuscular blockade can cause diaphragmatic dysfunction. Those parameters can also be seen by lung ultrasound in a live manner. So this is where your focus really plays now an important role in ARDS, and all of your patients should be monitored using your lung ultrasound.
Also, what I personally see is that the least clinical radiological dissociation is seen with the ultrasound, because it actually, we can see a real-time imaging and see the patient improve. So it becomes a much more sensitive tool to monitor the progress in patients, whereas X-rays can sometimes be misleading for about 24 to 48 hours. And also the sensitivity with a pleural effusion and pneumothorax is far superior, as the X-rays can be taken in different position in these patients. So yes, point well taken. Now, having done everything, the patient is still deteriorating. Now, Khilagati madam, what is the role of ECLS or ECMO in these patients, and when do we consider initiation, and when do we consider referring a patient for an ECMO?
The point that you have asked this question towards the end itself says you should have tried all your best maneuvers, what Dr. Kushraf sir has discussed and all the panelists has discussed so far, all the lung protection, ventilation, all your prone position, neuromuscular blockade, your PEEP strategy, everything should be optimized. So you have optimized the ARDS treatment and still your patient is hypoxemic and your patient has severe ARDS. Then I think, and the other indication is patient should be in severe respiratory acidosis, say, or pH less than 7.2. Patient has got hypercarbia, type 2 respiratory failure, PaCO2 is high, and there are high driving pressures, high transpulmonary pressures, and patient is hemodynamically unstable, and you are worried about ventilator induced lung injury and all those things. I think all societies recommend that you go for a veno-venous ECMO at this stage. So how does veno-venous ECMO help you? It is the same strategy where all speakers, the speaker as well as the panelists have discussed. It helps to give rest to the lung, and it's also protective ventilation to the lung. It improves your gas exchange, it improves your oxygenation, it reduces your CO2, and it also helps in hemodynamic stability. The most important thing is you can even extubate the patient, he can even eat, but don't forget that all this without treating the primary cause. What is the insult to the lung? That primary source control or the infection needs to be tackled. These are all not game changing parameters. You are just giving oxygen, you are protecting the lung till the ARDS settles or the patient improves and his immunity improves. So don't forget, so much we have discussed, but we should treat the primary cause. So there is no point in putting a costly treatment like ECMO without treating the primary insight. If it is a gram-negative sepsis or if it is a bacterial infection, if you don't treat that and then straight away go to ECMO, it's not going to help. And the most important contraindication is if you have some irreversible multi-organ failure and your patient has some etiology which is not going to say some malignancy, which is the inciting agent, or he has got an end-stage lung disease like acute exacerbation of IPF, which is totally, it's an end-stage lung disease waiting for transplant and things like that. So you need to consider the benefit-risk ratio at these stages. If they has a metastatic cancer and all those things, please look at the inciting agent, treatable cause, not treatable cause, phenoendotype the patient, and then decide on ECMO, because if your patient is not going to improve on ECMO, you are just going to take the patient straight away for lung transplant. So we should remember that. And the most important thing is, if you are instituting ECMO, do it early. Don't wait for too long till the fibrosis sets in, and then don't make things difficult for the transplant or the ECMO physician also to work on. So it should be instituted early at the right time when all your optimal strategies have failed. Don't wait too long and refer for ECMO early. And the most important point in our country is cost factor, a good team which can take care of the ECMO, and a good ICU setup, and the most important cost factor. So all these need to be considered if you want to put a patient on ECMO in our setting.
Also, what we need to understand when we talk of ECMO is that the ECMO is a bridge. When we talk of transplant, it's either a bridge for transplant for chronic respiratory issues, or in these cases of ARDS, they were giving the patient time to recover till the best possible medication can act. So which is why early initiation within 7 days has seen the best optimum results for mechanically ventilated patients. Another point which I'd like to add is that if there is an irreversible neurological injury, then there's no point in putting the patient on ECMO. So that is something which needs to be taken into consideration. Any irreversible cause of recovery should be excluded and should be a contraindication for an ECMO. And ECMO is a bridge. Do it early within 7 days, give the lung time, do it before the fibrotic phase sets in, and then you have good chances of recovery. Now, even the ECMO has failed. Now, Alisha Chaudhary, I'm going to ask you a question which is seldom practiced in our country, yet which is so very important, is when do we consider lung transplant in patients of ARDS?
So like Tilaga ma'am said that, optimal strategies have failed, ECMO has been given, now even ECMO has failed, right? So now the thing is lung transplant. So all your known medical management, ECMO, everything has stopped working. You've done your best and you don't know what to do next. Then you need a new set of lungs. You need to make sure it's an irreversible lung damage. You cannot get, patient is not going to improve. The next thing could be COVID-19 ARDS, where we saw a lot of, rise in lung transplants. Sometimes your ARDS can be associated with other chronic lung conditions like ILDs on emphysematous lungs. So in those cases also you can consider. The other thing which we should remember is, even when referring for a transplant, you should know what is the, life expectancy of the patient further. No associated sepsis, septic shock, or other multi-organ involvement, because obviously even after doing the transplant, the patient is not going to come out. So looking at, you should have exhausted everything, before referring your patient for transplant.
I absolutely agree that transplant is only the last option in acute cases of ARDS and not when we are considering. Yes, sir. Sorry.
Yeah, no, I would beg to differ a little bit that ECMO has failed, therefore transplant is not the right sentence. ECMO never really fails. It just may not work and not be sufficient enough, but you need to continue the ECMO till you can do the transplant. So just one proper take-home message so that people don't the audience doesn't get the wrong information. ECMO can go on for a month, 2 months, till the transplant can be sorted, and definitely transplant is the final destination that a diseased lung would need.
If you've considered transplant and if you are confident that you're going to put the patient on transplant, you've referred the patient, he's on the transplant list, she's on the transplant list, the family wants everything to be done, then ECMO is the bridge. The only challenge when we have a patient on prolonged ECMO is bleeding, blockage of the airways, is infection. So as long as those things are taken care of, like Dr. Bhajan said, ECMO can go on. We've often seen in COVID, when we've referred patients for a transplant, we waited a couple of months. We've had patients on the ECMO for a couple of months before they've been transplanted. So yes, there's no time limit for an ECMO. If the patient can survive the ECMO while waiting for the lung, by all means continue with the ECMO.
Absolutely.
So that ECMO becomes a bridge, and managing the complications often causes the death of the patient before they can actually get the lung. Now, we've done everything, sir. There's nothing. Now we've also considered transplant. Probably the patient gets a lung, the patient survives. But is there any hope in future where we can avoid ECMO, we can avoid transplant? Are there any newer drugs which can help in treating ARDS? What is the role of avipaptidil in these patients of ARDS, or any other new molecule which is in the horizon, sir?
So avipaptidil is one of the drugs which has been used quite a lot in India and a little bit in the USA. I don't think this can be compared to any of the other basic management strategies on ventilation, ECMO, ARDS that has to go on. But the few studies that they have done, they've done over 1,000 patients in India during the COVID time and even beyond. So the COVID ARDS, it is supposed to have a role. What it actually is, I have not used it personally, but I was on the ad board, so I understand the drug a little better. What it has is it's got a vasoactive peptide, which is there naturally present in our body. And when you have ARDS, you have very little VIP in your body. So you need to give that VIP exogenously. And that has, there are case reports which have shown dramatic improvement within 5 days on the PF ratio, improving to 200 from 50, and the X-ray shadows almost clearing. It's a bit too hard and too good to believe, but they have got a lot of data now, and there are about 10,000 vials that they have used across India, and the survival ratios are high. I would definitely again say that this is not a supplement or a replacement to any of the treatment that we are doing for ARDS, but we need much more data to use it. It is used in a succession or a exponential increase of the dose. The first day you give 1 vial, which is 150 mics, second day 2 vials, and third day 3 vials. The reason you do this is hypotension can happen because it's a vasodilator. So that's all I know about but no first-hand information.
Thank you, sir. And any emerging therapies, anything which we can look out in the future?
Prostacyclins, nitric oxide has all been tried. They have used simvastatin, they have used simple drugs like aspirin, but I don't think this is any replacement. We need much more data on this.
Absolutely, and more randomized controlled trials in the future. Now, that was a fantastic discussion with all my panelists who've answered each and every of my question. Now, we have also had more than 1,700 logins from across India who had the privilege of hearing Dr. Bhajan's lecture and listening to the esteemed panelists give wonderful answers and teaching the audience about ARDS and why it is so important. A topic which is at the back end of Fishman and left towards the very end before the exams, and we are also scared of the ICU running helter-skelter when we have a hypoxic patient in the middle of the night, afraid to call the on-call doctor or the HOD. Now, for the sake of our audience who've been so passionate and have been listening to us for the last 2 hours, they've put up a lot of questions. Some of those questions have already been answered, but I still want our faculty to repeat those answers so that we have a proper take-home message like Dr. Bhajan has said. So I'm going to start with Dr. Tandon. I'm going to ask him the question I've asked Dr. Thilagavati Madam, that what is the role of corticosteroids and what evidence supports it? In brief, if you can answer this.
Yeah, I think we already discussed the DEXA-ARDS trial.
Yes. So I want Dr. Abhishek to put his 2 cents before I give you what question I asked Dr. Agrawal, that is neuromuscular blockade.
Yeah.
I'm going to play past musical chairs with questions.
So, Dr. Gurumurthy has already emphasized upon it. Steroids in ARDS, we have conflicting evidences. dexamethasone or methylprednisolone, a steroid which has a low mineralocorticoid activity, except if it's for sepsis or a septic shock, where we can bring in a hydrocortisone as well. Not for mild ARDS once we are moving into a moderate or a severe ARDS, but early in the phase of the disease, not later.
Super. Thank you so much that we need to give early steroids with potent glucocorticoid activity and least mineralocorticoid activity and take the underlying condition into consideration. Now, moving to Gurumati Madam. Madam, another question which we've answered already, but I want your take on the role of neuromuscular blockade in ARDS management and how soon should we start it for our audience?
So the simple answer is you need to get your you need to get the ventilation right. So to get the ventilation right, depending on the patient, you need to give the neuromuscular blockade, as well as you have to balance between the sedation and neuromuscular blockade to keep the patient calm so that your lung protection ventilation works. That's the one take-home message, I would say. So there is no one size fits all. You can balance between these two to keep the patient calm and help ventilation to do the job.
And prevent P-SILI and ensure that
So lung protection strategy.
Correct. And we achieve controlled ventilation for the first 48 hours and then we stop it if required. Now, Dr. Agarwal, can you please tell me that are there any emerging therapies such as stem cell therapy or gene therapy that hold promise in ARDS treatment? This is a question from Dr. Krishna Yadav from Maharashtra.
Yeah, I think Dr. Kushrav has already really nicely answered that though we have new therapies in terms of avibactam, most of the other therapies like your nitrous oxide and the other therapies have not really, simvastatin, aspirin, has not really given us any, landmark trial results. And so we have got limited evidence for those. Even your stem cell or gene therapy, we do not have any evidence right now about whether they can lead to mortality benefit or even length of ICU stay in terms of ventilator days. So currently, the standard therapies that we have just discussed have got the trials giving us evidence, whether there is benefit or not. None of the other therapies have really shown those kind of promising results till now.
So one point I want to make here regarding the newer, it's not a newer therapy, but remember in COVID, we used to try tocilizumab and other things. So you can add some immunosuppression to your ARDS, provided you have a patient in the hyper inflammatory phase. Based on your biomarkers like IL-6 or CRP, ferritin, D-dimer, all these markers, you can add a second immunosuppression which can take off the steroid sparing effect. You can add some immunosuppression. There is a role for immunosuppression in a particular phenotype of the patient.
When we're talking about cytostorm and the cytokine storm and the role of immunosuppression, we need to be careful about underlying sepsis and infection, because those levels also can cause an elevated inflammatory cascade and have elevated markers. So we need to be careful before we use that. But yes, madam, point well taken. Tocilizumab was used in special situations in COVID, ARDS, and I have personally seen patients recover. Yes, but now we don't see that much COVID and probably other reasons. So we need to be careful where we place this drug in today's management. Now, moving to Dr. Alisha Chaudhary, sir has already said about influencing of prone ventilation, ECMO and rescue therapies, but I want your take on this. What are rescue strategies? How is prone positioning? And again, what's the role of ultrasound and why is it so important in ARDS? This is a question by Dr. Bhavya from Maharashtra.
So the only rescue strategy which has stood the test of time is actually prone positioning, right? All our trials, placebo, everything has advocated that. So definitely after you have tried your low tidal volume ventilation, you have optimized your PEEP, still patient is not improving, your P/F is less than 150, you need to prone the patient. That's it. Because remember, ARDS is a heterogeneous disease and sometimes the dorsal lung is more collapsed compared to your non-dependent lung. So they respond well to proning. So early proning would be better. The procedure says 16 hours, but if you are seeing benefits in your patient, you can prolong proning hours also, but making sure that you are taking care of his eyes, his pressure source and the tubes in the lines, right? So people have proned up to 48 hours also, but keeping in mind all the other issues so the patient doesn't land up in complications. We have other rescue strategies like recruitment maneuvers and all. they have been tried, but if you ask data evidence that is there going to be mortality benefit? No. So not at all recommended. Probably maybe in expert hands, because hemodynamic instability is one dreaded complication of that. So definitely proning is a yes. Other recruitment maneuvers may be, depending on your expertise.
Can I
Keep
just
all the-
add a very quick
Yes, sir.
comment? Yeah. So proning, we should all be doing very early and very quickly, but you need a team to do that. You need at least 4 to 5 people, which needs a proper training, briefing, debriefing. What you should be prepared when you are proning is to unprone the patient or make the patient supine. Because if there is a hemodynamic instability, if the endotracheal tube has slipped out or a trachea has come out, you need to quickly unprone the patient. So you don't do it at times when there is less staff. So that is very important practical point. What happens if the patient develops a cardiac arrest on proning? So there is, you need to unprone and then you are wasting time. So there is very little evidence and it's picking up where you can do a prone CPR also. That's just one thing that can be kept in mind. I've done it only on 1 or 2 patients, but not really so. What you need to do is have a proper team to unprone them immediately when the need arises. So I think that's one thing we need to also keep in mind.
To add to what Sir told, the other thing about hemodynamic instability, people think that if the patient is hemodynamically unstable, we can't prone. See, the things are like differing. It's emerging right now. You can prone, because if you remember Sir's slide, that these patients suffer from a lot of RV dysfunction, hypoxia and hypercarbia. That itself could be also, contributing to the hemodynamic instability. So once you're going to prone, definitely that is going to improve. So your hemodynamic instability requirement of vasopressors might also come down. And the role of ultrasound, what Avya asked me was, it is definitely very helpful when you're proning these patients, when you want to know, those consolidation or those B lines are disappearing or not, are A lines coming or not. So definitely a quick tool, right? Every time, otherwise you'll have to wait for an X-ray after 24 hours or 16 to 24 hours, then see whether your prone has worked or not. Sometimes bedside monitoring can make, help you take quick decisions.
A couple of points I want to add to what my esteemed panelists have said, that the ultrasound is so important because it's real time. You don't need to wait 40 minutes for an X-ray because you can't wait there for 40 minutes. You're going to ask the X-ray, you're going to leave, and then you're going to depend on someone to send you the picture of the X-ray. Another practical thing which we need to understand when we're proning the patient is have more hands, have an extra nurse, keep the nurse prepared, because when the emergency or the line will come out, you'll have some orifice which starts going haywire, will be an issue, becomes a challenge, which is what we need to keep in mind. And also proning and hemodynamic instability are not contraindications, because ARDS is what is causing the hemodynamic instability and proning is correcting the ARDS to a certain extent. So solve the ARDS, everything else will follow suit. That is what I personally feel. Now, I'm going to ask Dr. Bhajan that are there any new biomarkers or emerging techniques to monitor progression of ARDS or help in the diagnosis of ARDS?
I'm not very aware of many biomarkers, but yeah, there are TREM and STEM biomarkers that are coming up. There are interleukins which we can follow but to differentiate the phenotypes. But what is emerging is more than the biomarkers. It is the phenotypes that we are trying to understand. And once we understand which patient would benefit from low versus high PEEP, low versus high fluid therapy, I think we will be better off. But if anybody else can add to my answer, I would be happy to learn from
any role of serial inflammatory markers, CRP, procalcitonin levels when you're monitoring ARDS? That's what, yes, ma'am.
Yes. I think, that CRP, D-dimer, ferritin, all those markers we already know, but there are some markers which are, I think, investigational or probably not available in our country, which we can measure. For example, you need to address maybe like epithelial injury, there are markers, endothelial injury, there are markers. If your coagulation cascade has a problem, that has few markers. And for example, if I say KL6, surfactant protein D, indirectly it shows type 2 pneumocyte damage injury. So you can measure, but KL6 is in a big form, which is measured abroad. But I think in interstitial lung disease, it's in a big way to demonstrate type 2 pneumocyte injury. But I think in India, it's not available. We can't. Then
coming in 2 months. 2 months. a certain company, I can't use the name obviously. So
Okay, okay, fine.
It will be out. The
Okay.
cost of the test will be a question.
I know. Hey, so in the real world, it will take some more years before we get normalized to low cost and things like that.
And
So
you need to do a
apart
trend.
from that,
You need
Yeah.
to repeat the biomarkers. It's not a one-time thing. So
Not a
that
one-time.
increases.
so you can use procalcitonin, you can use CRP, all our ferritin, D-dimer, everything can, and even thrombomodulin, like plasminogen, activating factor, fibrinogen, so many. If coagulation is a problem, we have learned from COVID all this, no? There is a phenotype where hypercoagulation is the main problem and the oxygen saturation drops because of microthrombi. That is one phenotype of ARDS. So in that particular patient, you can try to investigate more to find more biomarkers. But as of now, there is no clear-cut evidence saying this biomarker says this or which one helps. Maybe you can say if you want early ARDS, you can go for endothelial injury markers like SPD and KL6. And then if you have, you want to, prognosis marker is what we are talking about, like CRP, D-dimer and all those things. But I think then you can have therapeutic markers. For example, we are talking about tocilizumab. Then is IL-6 a problem? Then we can institute. I think therapeutically you can go on in that particular patient which works, we can try to find out. But there is
the best biomarker is that which prevents the biotrauma.
Correct. And the Vidi, basically at the end of the day.
Yeah.
So moving on to Dr. Agrawal, we have a question by Dr. Nagrecha Pooja from Daman. That the new Kigali definition of ARDS, has it changed the concept of ARDS diagnosis? Has it helped and made things easier for us? Why was this change adopted is what she wants to know.
I think, a very inquisitive question that we all have, that why did we actually do this? So I think during the COVID times, it was seen that many resource limiting settings areas saw these patients of severe ARDS that did not have regular ABG parameters. Then many patients were put directly on NIV and then referred to a higher center. So in those cases, making a diagnosis of ARDS from the previous definition was difficult. And now that we have now that most of your primary settings have upgraded to some level after COVID, like HFNC is available at many places, NIV settings are also available at many places. So you will very commonly see patients coming to you with having these settings in the background, or you will be managing these patients where you do not have a proper ABG settings. So to encounter these kind of scenarios, the newer definition included these patients as well, since there was so much of data now available and we are going to be seeing these patients. So to help us in improvising our diagnosis of ARDS itself was the newer definition come up. And the USG guidance has really helped in settings where you have an ultrasound machine on your unit, on your floor. I mean, definitely it helps us in the decreased waiting time, bedside live evaluation of the patient with reduced radiological, the radiation exposure to the patient. So having all of these parameters included together helps in diagnosis and in further prognosis of these patients.
Fantastic. Now, we've answered all the questions except this one last question, which is asked by Dr. Professor Ajay Lanjewar sir from Nagpur. A very honest question which is asked, and I'm keeping this question open to all my panelists, is that do the experts believe that ARDS is not a single specialist call and must be taken by two or more specialists? In short, is it a teamwork which is important in managing ARDS? I want an answer from everyone.
Yeah, I guess absolutely. So single-handedly managing a patient of ARDS is almost always impossible. The team not necessarily needs to have more than one or two doctors, but doctors, trained staff nurses, technicians and assistants, and without an amalgamation and a collaboration of everyone involved, it's not possible to manage a patient of ARDS. This is what my view is.
I think, proning can't be done with a single person. Ventilator, if you are a pulmonologist, you are not going to stay in intensive care 24/7. So I think it needs a teamwork, no doubt about it. And proning needs a team by itself. Maintaining the proning also needs a team by itself. And ARDS is a complex disease, heterogeneous disease. I think multiple consultants will be involved in this. You will need an ID specialist at certain times, and then some ICU care specialist. And in a different patient, you will need, there may be abdominal sepsis, there may be blood sepsis. You will have different causes of ARDS. I think it's a teamwork which brings the patient out. But I think if you follow these protocol for ARDS, I think this is the wonder you can achieve. You can bring patients out, and very, very rewarding to the family as well as to the treating physician.
So yeah, I would also like to add to that, that as I always say in my ICU rounds, that ICU outcomes are largely dependent on the nursing care more than the consultant care, because those patients require every minute nursing care, and not just coming and giving a drug. They require they're bed bound patients, they're on ventilator, they will require continuous care. So your ICU nurses have that kind of experience also with the patient. We also see to it that if there is a nurse posted continuously on a day duty, then they get same patient handover so that they can see the progression of the patient. So definitely it's a teamwork. And as Dr. Gurmiti said, that you may require other specialist help as well. So an ID specialist, a cardiologist, you will require a CT wave surgeon if you want an ECMO, you will require a perfusionist when you're moving on to an ECMO, you will require a transplant team. So it is definitely going to be a multiple teamwork when you are dealing with a severe ARDS patient, when you're going to that extent. Yes, definitely over there. And I would also like to add to that question of biomarkers. So in our ICU, we very commonly use CRP. It is a low budget marker, though it is not specific, but very good at understanding. If you relate it with a clinical scenario, you can really help in management of those kind of patients. So if you are in a resource limited setting, that is a marker that really can help you in guiding your patient's management further.
I think the difference is between rounds and round the clock. We come for rounds and we need round the clock management of our ARDS patients. So that's what we need. To answer Dr. Lanjeva's question, that ARDS diagnosis can be made by a single consultant. I don't think we need a team to diagnose ARDS, but definitely managing ARDS is not a one-man show and it requires a team effort. So before I thank and
Can I just very quickly make a comment? Yeah, so basically what he's asking is more specialists. Yes, definitely we need a pulmonologist, an intensivist, a nephrologist, and the works. I divide doctors into two types. One is MOD and one is SOD. So we are the multi-organ doctors, and pulmonologist is a single organ doctor, nephrologist is that. So we need MOD and SOD both together. We have thanked our nurses, we've thanked everybody, but one major department we need during ARDS management is the physiotherapy department and the nutritionist. So patients who are long-term on ventilation, we are giving them NMBAs and we are ventilating them till endlessly. They will develop ICU atrophy, muscle atrophy, neuropathy, myopathy, and these patients, only two things have helped: early adequate nutrition and early mobilization out of bed, even with the ventilator on, even with the ECMO on. So I think it's a team effort, and I'm glad that Dr. Ajay asked this question as a kind of take home. It's not one person's disease, and it is a combination of all the efforts that can send an ARDS patient home.
So having said that, I think as a pulmonologist and a critical care person, so both, yes, I do understand like what he has asked. It's needed, especially because most of your ARDS cases can be due to chronic lung diseases, also like associated chronic lung diseases. You definitely need a pulmonologist there. And as the thing, round the clock or just for rounds, what Avya also told, right? Both that concept is also well taken place. So definitely a good team effort, good robust protocols in your ICU with proper ARDS ventilation charts and prone charts, and you can do wonders for your patient together.
Before I thank and close today's discussion, I want a final take-home message from all my esteemed panelists, starting from Dr. Thilamati Madam, and your final message for the audience who've been so keen and interactive today.
So ARDS, you need to understand the physiology behind it, the cause of the ARDS. Just talking about ARDS, lung protection strategies, and then all the drugs doesn't help at all. Get to the root cause of the problem. That is the key to success. You have some gram-negative sepsis. If you don't treat it, however good your ventilation strategies are, however good your other protective care are, you are not going to get the patient out of it. So get to the root cause of the problem. Identify the insulting agent. If you can avoid it, stop it. Please try that as a first measure, along with all the different strategies which the whole panelist as well as our speaker has said. Thank you. Thank you for having me here. Thank you.
Alicia?
So as already ma'am has said, just to add to that, I already mentioned, a good team, good robust protocols to diagnose, to go through stepwise management of ARDS, what sir told, early nutrition and early mobilization, early prone, and know when to refer for ECMO early.
Okay, Sumita?
Yeah, I would like to say that you see your patient as a whole, not just the lung. I mean, there are so many parameters going on for a patient. And as Dr. Kushraf said that ventilation is just, managing the lungs. You have to treat the cause. So always whenever you're seeing a parameter derange, you have to understand what is the etiology behind it and you treat the cause. If you are going and following this path, you are treating your patient and hopefully patient goes home.
Dr. Tandon?
I would just like to add on one message for everyone listening that the field of management of ARDS is evolving very rapidly. We have a lot of new kids in the block, but we should not just use it up front or just keep on using it just because they've been mentioned in a trial or in an observational study or in a case report. Don't just dwell into anything that comes your way because it might actually be counterproductive. So stick to the basics and treat the disease entity as a whole.
And the master finally for his final comments.
So, I think ARDS is a very complex disease. So treat the underlying cause early, support the lungs by ventilating them soft and slow, and monitoring is the key. May use some non-ventilatory strategies as well, which would be individualized. And now it's the time not to treat ARDS as a blanket management protocol, but individualized therapy, personalized therapy, depending upon why the ARDS has been there, why is it not responding, and try to tailor the medications and the therapy for that particular individual patient. And please look after the weaning. The early tracheostomies, early intubations is the key, and early mobilization is the key. And post ICU, post ARDS care is very important because many of the times they later become cripples because of pulmonary hypertension. So the cause and the care and the treatment does not stop once you send the patient out of the ICU or the hospital, but you need to do regular follow-up. So I think that's very, very important.
I'm going to have a few off-label points for our audience to take home is involve physios, involve nutritionists. We may think that they add a burden to the treatment, but trust me, they are the ones who reduce the ICU stay. They are the ones who improve the quality of life and ensure that the patient gets discharged. Teach your residents, learn, keep yourself updated and teach your residents because you're going to be there on rounds. They are the ones who are going to manage the patient. And the minute they pick up things early, that's the time you're going to be easier to take a decision. And finally, for our pulmonologist friends, that we often say that we are not involved early, but as pulmonologists managing ARDS, get a critical care physician on board. Get someone like Dr. Bhajan on board because we may have a better outlook and a better insight in overall management of the patient and not just be a sort, but have someone who manages the mod as well. So thank you so much. I would like to thank my expert speaker, Dr. Bhajan, for teaching us and educating all of us so wonderfully well. My esteemed panelists for being so wonderful and answering all the questions repeatedly again, right from Gurumati Madam, Alicia, Dr. Sumita, Dr. Tandon, and last but not the least, the wonderful audience who stayed up till almost 10:45 on a weekday listening to us blabber and talk about ARDS, and to Dr. Amita Nini and the entire team of ICS for having this wonderful series of ICU webinar and ARDS and giving us the opportunity to be with you all. And thank you, Sipla, for conducting a smooth and sensational webinar. Thank you, everybody. Good night.
Thank you.
I think I need to thank Dr. Avia Bansal for being absolutely brilliant and keeping everybody on point, and Dr. Amita for always having me over for this amazing gathering. Fantastic having sharing the not the stage but the screen with the lovely panelists here.
Avia making sure that we were attentive throughout the discussion so that, repeated questions, we knew the answers very.
No. Brilliantly moderated, Avia. Yeah, brilliantly.
Yeah, absolutely fantastic.
Thank you. Thank you so much.
Thank you, everyone.